As a longtime foreign correspondent, I've worked in lots of places, but nowhere as important to the world as China. I'm Jane Perlez, former Beijing bureau chief for the New York Times. Join me on my new podcast, Face Off, US versus China, where I'll take you behind the scenes in the tumultuous US-China relationship. Find Face Off wherever you get your podcasts.
Well, hello there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach concepts and share tips on how to thrive in nursing school and at the bedside. Today, we're taking a walk into pediatric land with an overview of some common pediatric gastrointestinal disorders. So if that sounds exciting to you, I hope you stick around and listen to this episode. Before we dive into that, let's take a very quick minute for our listener shout out. And this one goes out to Julia, who says this: I just wanted to say big thanks for creating such an amazing resource and study option. I'm in my second semester of nursing school. I use StudySesh all the time, and I definitely see the improvement in how quickly I can memorize the material. Every time I drive or do something around the house, I listen to different episodes, and it helps a lot. So again, thank you very much for helping nursing students succeed. Thank you, Julia, for taking time to share your experience with StudySesh, and I'm really glad to be your study buddy. I want to wish you all the very best on your journey to become a nurse. So if you're curious what Julia is talking about, she's talking about StudySesh, which is my other podcast. It's a private podcast, and it's full of lessons that are really designed for you to be able to review and quiz yourself on material. So a lot of the lessons or episodes in StudySesh are PodQuizzes. And if you've listened to this podcast for a while, you may have heard me do some PodQuiz questions at the end of an episode. I will be doing some at the end of this episode. So if you find that helpful, then you definitely want to check out StudySesh. I'll put a link in the episode notes. Of course, you can always just go to the Straight A Nursing Student website and click on courses in the menu bar to find your way there. Okay, let's dive into pediatric GI disorders. Now, with pediatric GI disorders, there's quite a few of them, and tests in nursing school and your NCLEX are going to make sure that you can differentiate between them. So it's really important to know kind of the key things about each one of these common pediatric gastrointestinal disorders. So we'll start off by talking about gastroesophageal reflux disease. And you probably just call this GERD, G-E-R-D. And this is a condition that involves stomach acid repeatedly flowing, kind of backflowing up into the esophagus, where it causes irritation to that tissue. Some risk factors for GERD include prematurity, cystic fibrosis, neurological impairments, scoliosis, hiatal hernia, esophageal atresia, obesity in an older child, and asthma. And when GERD occurs in infants, it often does resolve on its own by around 12 months of age. So some signs and symptoms of GERD include crying and irritability because it's painful, vomiting or spitting up repeatedly, the infant having a poor appetite or refusing to eat or having difficulty with feeding. One key sign is arching of the back in infants. That could be on an exam because it's very specific. Weight loss or an inability to gain weight, which makes sense. If they're not getting good nutrition, they're not going to be gaining weight. They could be choking or having difficulty swallowing. Coughing could occur, wheezing could occur. They could get these secondary respiratory problems. And then abdominal pain and heartburn may be experienced by older children. So again, that would be the signs and symptoms of gastroesophageal reflux disease. And then complications of the condition include failure to thrive. If they're really not eating and they're not gaining enough weight, they could have failure to thrive, and they could develop esophagitis, which is just that terrible inflammation of the esophagus. It's very, very painful, and it can lead to other complications if it's not treated and could even result in esophageal perforation. So how do we treat GERD? So some key things to do are to offer small, frequent feedings for the infant rather than larger meals, more frequent feedings that are smaller. And then really important to keep the child upright for about 30 to 60 minutes after eating. Now, if breastfeeding, the mom needs to avoid foods that can cause reflux, such as spicy foods or caffeine. There are others. Those are just a couple of examples. And then some infants benefit from avoiding soy and cow's milk. We could also thicken formula or breast milk. And another option is medication. This could include H2 receptor antagonists like ranitidine or a proton pump inhibitor such as pantoprazole. And then in severe cases, a surgical procedure called a Nissen fundoplication may be required. And in this procedure, the fundus of the stomach is wrapped around that distal esophagus to kind of create a sphincter, more or less. It creates a barrier to that gastric acid from coming back up to the esophagus. And the result of this procedure is decreased reflux, but do note that it impairs the child's ability to vomit. So parents have to understand that if their child has a tummy ache, they're not going to be able to vomit and feel better. They may need additional treatments for abdominal discomfort, abdominal disorders in their child. Okay, so that was GERD. Your highlights are it's acid reflux. The child's going to be crying, irritable, vomiting or spitting up, having difficulty with feeding, maybe arching their back if they're an infant, and not gaining weight. We're going to give small, frequent feedings and keep the child upright after eating. And some children may require surgery called a Nissen fundoplication. So that was your too long, didn't read version. Okay, let's move on to Hirschsprung disease. So Hirschsprung disease, or HD, is a congenital disorder of the colon in which segments of the colon lack ganglionic cells. And what happens is that these areas of the colon have decreased motility, and this can cause obstruction. It is often associated with other chromosomal abnormalities, such as Down syndrome. Not always, but often. So signs and symptoms of Hirschsprung's disease include failure to pass meconium or stool, abdominal distension, which makes sense. If they're not passing stool, their belly is going to get distended. They could have bilious emesis or be vomiting bile. They would have poor feeding and a refusal to eat. They would have episodes of diarrhea interspersed with episodes of constipation. And something called Scort sign or blast sign could be present. And this is the explosive passage of diarrhea and gas after digital rectal examination. And the reason this occurs is because that digital rectal examination temporarily relieves the obstruction. So the child has just an explosive release of diarrhea and gas. And again, that's called Scort sign or blast sign, you may hear it called. And then another hallmark sign of Hirschsprung disease is foul-smelling ribbon-like stools. And they're ribbon-like because there's this partial obstruction. So the stool is just kind of trying to get out, right? So it's going to get around that obstruction and get compressed into this ribbon-like shape. And then older children may have a palpable mass and visible peristalsis. And then what would be some complications of Hirschsprung disease? One is toxic megacolon, which is severe inflammation of the colon that can result in colonic rupture. We definitely don't want that. Enterocolitis, which is inflammation of the bowel. Volvulus, which is when a loop of intestine twists around itself to cause an obstruction. And it could also cause anal strictures, which may require dilation. And then what about treatments for Hirschsprung disease? Basically, the child will need surgery to remove the affected area of the colon. And surgical procedures for this have advanced, and nowadays, most cases, the child's rectum and anal sphincter function remain intact, so no colostomy is needed, usually not even a temporary colostomy. They can do this all in one procedure, which is really great. So your too long didn't read or too long didn't listen version for Hirschsprung's disease is signs and symptoms would be failure to pass meconium or stool, vomiting bile, that foul-smelling ribbon-like stool, those episodes of diarrhea and constipation, maybe that blast sign after a digital rectal examination, and then that palpable mass in an older child. And that palpable mass is stool. And then looking at the treatment, it's going to be surgery to remove the affected areas of the colon. Okay, so far we've talked about GERD and Hirschsprung disease. Now let's talk about intussusception. So intussusception is a condition in which a section of the intestine folds inside or telescopes inside another section, causing obstruction and edema. It's most common between the ages of 3 months to 6 years, and within that age range, way more common in like that under 2-year range. And boys are 4 times as likely to be affected as girls. The exact cause is unknown, though viral infections have been known to be responsible in some cases. So what are the signs and symptoms of intussusception? So one is colicky abdominal pain. And with this pain, it can be pretty severe. The child could draw their legs up to their chest while crying or even screaming in pain. And then when the episode passes and that colicky pain resolves, they act normal. And then they have another bout of pain and really, really painful and screaming and crying and drawing their knees up to their chest. They could be vomiting. They would have red jelly-like stools, which is mucus and blood mixed together. And they may have a sausage-shaped abdominal mass that may be palpable when the abdomen is soft, not during like a colic attack, but when the abdomen is soft, this could be palpable. And then, of course, abdominal distension, which makes perfect sense. And then the complications of intussusception could be that telescoped intestine blocks blood flow enough, leading to ischemic bowel. And that is a really bad situation to be in. It causes terrible, terrible problems in the body, not to mention sepsis and peritonitis, which would be another complication. And then GI bleeding can also occur. Treatments for intussusception include an enema to infuse either fluid or just air into the GI tract, which pushes that telescoped bowel back into its proper position. And then if the enema is ineffective or if the child keeps having intussusception occurrences, they will need surgery. So your quick overview of intussusception is colicky abdominal pain, drawing the knees up to the chest while crying in pain, and those red jelly-like stools. Very, very common for tests to ask about that. I would also add that sausage-shaped abdominal mass. And the treatment is an enema. Pretty simple, right? Hopefully it works and the child does not need surgery. Next, we'll talk about hypertrophic pyloric stenosis, or HPS. And this is a condition in which the pylorus thickens and becomes too large. So the pylorus is there at the entrance from the stomach to the small intestine. And if it's not working properly, if it's too large, too thick, it's going to block the passage of food from the stomach into the small intestine. So the result is the child's eating, and it can't go anywhere. So we have severe and forceful vomiting. It usually develops between 3 and 5 weeks of age, so little tiny babies dealing with this, with males having a 5-to-1 incidence when compared to females. While the cause of hypertrophic pyloric stenosis is not totally clear, we do know that certain antibiotics can lead to an increased risk for HPS, and that would be azithromycin and erythromycin. Other risk factors include maternal smoking, bottle feeding, and a family history of HPS. So the signs and symptoms associated with this condition include that forceful or projectile vomiting after feeding. It makes perfect sense, right? There's nowhere for this food to go. They're going to force it back out. The baby would have weight loss, dehydration. They're hungry all the time. They throw up and then they immediately want to eat again because, of course, the little guy's hungry. They could also have an olive-shaped or olive-like mass in the right upper quadrant and even visible peristalsis. Complications of hypertrophic pyloric stenosis include failure to thrive, electrolyte imbalance, and severe dehydration. So all of those complications make perfect sense. Baby's not getting any nutrition. They're not going to get nourishment. They're not going to thrive. They're not going to gain weight. Electrolytes are going to be out of whack, and they're going to be fluid volume deficient. The treatment for HPS is a surgical pyloromyotomy. Hope I said that right. And this is a procedure in which the surgeon makes small cuts in the pylorus so that food is able to pass from the stomach into the small intestine. So your quick overview of hypertrophic pyloric stenosis is that food cannot get from the stomach into the small intestine, so baby eats and then projectile vomits. They're hungry all the time and could have an olive-like mass in the right upper quadrant. They're going to be not gaining weight. They could have electrolyte imbalances and dehydration. And the fix is surgery. We're going to make some adjustments to that pylorus so that food is able to pass from the stomach into the small intestine. Let's take a quick little break here, and then when we come back, we'll dive into biliary atresia, Meckel's diverticulum, and short bowel syndrome. Then we'll do some PodQuizzing to see what you learned. As the weather warms up and the days get longer, does your schedule get as full and as fun as mine does? Or if you're a student, you've probably got midterms and projects coming due. So really, who has time to cook? With Factor, you don't have to. Their ready-to-eat meals are not only delicious, they're dietitian approved and ready to eat in just 2 minutes. And if you like variety, Factor has got you covered. Choose from over 35 meal options each week, including options to fit your lifestyle, such as calorie smart choices, vegan and veggie, meals packed with extra protein, and even keto meals. Plus, they have over 60 add-ons to choose from every week, including snacks and beverages to keep you going and feeling good all day long. So if you're loving the spring weather and spending more time outside and less time in the kitchen, then it's the perfect time to try Factor. Head to factormeals.com/nursemo50 and use code nursemo50 to get 50% off. That's code nursemo50 at factormeals.com/nursemo50 to get 50% off. So we're back, and now we're going to talk about biliary atresia. So this is a progressive disease of the extrahepatic biliary tree that causes biliary obstruction, and it is the most common indication for liver transplantation in children. So it's a very, very serious condition. Signs and symptoms of biliary atresia include jaundice, appearing from as early as the time of birth up to about 8 weeks of age. The child would have pale stools that is associated with a liver disorder, pale stools, dark urine, which is due to excretion of that excess bilirubin. An enlarged liver and splenomegaly could be present as the condition progresses, and on labs, elevated conjugated or direct bilirubin. And so what about complications of biliary atresia? Probably thinking problems with the liver, right? So cirrhosis can occur if the child is not treated. Cirrhosis could occur within 6 months, and liver failure could occur within 12 months if this issue is not addressed. And then, of course, with that, like with all these GI disorders, failure to thrive is a potential complication. So how do we treat biliary atresia? child's going to get surgery. There's a surgical procedure called a Kasai procedure, Kasai, and this is a surgical procedure to restore that proper flow of bile. But even with the Kasai procedure, children will often still need a liver transplant, and especially will need a liver transplant if that procedure is ineffective. So your quick overview of biliary atresia is that it's a problem with biliary obstruction and the flow of bile. Child's going to be jaundiced, have pale stools, and dark urine. The treatment is going to be surgery to correct the bile flow, or possibly even a liver transplant. Next is Meckel's diverticulum. And what this is a small little outpouching that extends from the wall of that lower small intestine. This outpouching is actually a little remnant of tissue from embryonic development, and it is the most common congenital abnormality of the gastrointestinal system. Now, this pouch lining can be made up of acid-secreting tissue or pancreatic tissue, and in most individuals, though, this diverticulum doesn't cause any symptoms or any problems. However, when it does cause problems, it's from acid secretion, causing intestinal ulcers in these patients. And really, the main sign of Meckel's diverticulum is painless rectal bleeding. That's about it. So, because they may not have any other associated signs and symptoms, but if the child has painless rectal bleeding, they're going to get looked at and worked up for Meckel's diverticulum most likely. What if we don't get this treated? What would the complications be? Well, this bleeding ulcer can be very detrimental. It can lead to anemia. Bleeding ulcers can perforate, leading to abdominal pain, leading to severe infection, leading to peritonitis. And then as a consequence of this diverticulum, the child could have intussusception, which could lead to intestinal obstruction. And then volvulus is also another complication that could occur. And remember, a volvulus is when a loop of intestine twists around itself to cause an obstruction. So you're probably thinking, we don't want any of that. What's the treatment? So the treatment for Meckel's diverticulum is basically surgery to resect that diverticulum, and then problem solved. So your short version of Meckel's diverticulum is painless rectal bleeding and ulcers. All right, let's move on now to our final one, and that is short bowel syndrome. So short bowel syndrome is a condition of malabsorption that is a result of small intestine surgical resections, especially if the child has a lot of small intestine resected at once or over multiple procedures. It can also be from diseases that cause a loss of nutrient absorption, such as necrotizing enterocolitis, and it could be due to congenital malformations. Children with short bowel syndrome are unable to fully absorb necessary nutrients and fluids. It is the leading cause of intestinal failure in pediatrics and often results in the child receiving parenteral nutrition. So, signs and symptoms of short bowel syndrome include poor weight gain, poor growth, dehydration, electrolyte imbalances, and watery diarrhea. Because they're not absorbing the fluid, it's just going to come out in the stool. So, what about the complications of short bowel syndrome? Well, obviously, severe dehydration can occur and severe electrolyte imbalances can occur. Again, failure to thrive is a possible complication. The child could also develop intestinal failure associated liver disease. So, liver disease associated with intestinal failure and development of an oral aversion and poor appetite. What about treatments for short bowel syndrome? One is parenteral nutrition, and the goal is to not have to use this forever. So the child may start with some parenteral nutrition, followed by a slow introduction of enteral feedings. We also want to optimize fluids in this child that may need IV fluids for a bit. They also will get vitamin and mineral supplementation. And then the child with that oral aversion or that poor appetite may get an appetite stimulant. And then for the child with diarrhea, they may get a medication to reduce or alleviate that diarrhea, such as loperamide or cholestyramine. And then surgical intervention may be utilized in some cases to lengthen or reconstruct the small intestine. And then some children may be candidates for small bowel transplantation. So your quick overview of short bowel syndrome is the child's not able to absorb nutrients. They have poor weight gain, dehydration, electrolyte imbalances, and watery diarrhea. We're going to treat them with parenteral nutrition, hopefully wean them towards enteral feeding, optimize fluids, vitamins, minerals, stimulate their appetite, address their diarrhea, and they may need surgery. Okay, so as promised, let's do a little bit of pod quizzing. And if this is your first time with a pod quiz, welcome. You're going to love it. So what I do is I ask a question and then pause for a bit to give you some time to answer, and then I tell you the answer. Basically, we're doing flashcards with your ears. Okay, question 1. Which condition involves red, jelly-like stools and the child drawing their knees up to their chest when they're in pain? That was intussusception. Very good. Next, what condition involves an olive-like mass and projectile vomiting? That is hypertrophic pyloric stenosis. And I'm assuming that little olive-like mass is the hypertrophic pylorus, I would assume. Okay, next question. Which condition is treated with a liver transplant? That is biliary atresia. Which condition can cause esophagitis, failure to thrive, and swallowing difficulties? That was GERD. Good job. Which condition involves bilious emesis or vomiting bile and foul-smelling ribbon-like stools? That was Hirschsprung disease or Hirschsprung disease, however you say it, Hirschsprung. Okay, what condition is treated with a fluid or air enema? That was intussusception. Excellent. Which condition involves painless rectal bleeding? That was Meckel's diverticulum. Which condition requires at least temporary parenteral nutrition in most cases? Short bowel syndrome. Good job. Which condition involves a failure to pass meconium? That is Hirschsprung disease. Which condition is associated with jaundice of the newborn? That was biliary atresia. And last question, which condition is treated with a Nissen fundoplication? That one is GERD. So there you have it. You have now done a pod quiz, and I bet you loved it. So if you like studying like this, reviewing like this, if you like doing flashcards, but you don't want to necessarily sit and stare at flashcards, you can get Study Sesh. It's got thousands of these questions over many different categories. And you can just listen and do the flashcards with your ears. In Study Sesh, there's also some drills where we drill down on things that you just have to memorize, like cranial nerves and the blood flow pathway through the heart and things like that. There's some power hour where I go into a deep dive onto a concept, and then some case studies. So the great thing about Study Sesh is that as I add to it, and I am planning to add some more case studies and some more power hours and things like that, you get those without having to re-enroll or re-sign up or pay any extra. So once you're in Study Sesh, you're a Study Sesher for life. Okay, well, I'm really happy that you studied pediatric GI disorders here with me today. And I'd love if you would come back and hang out with me next week. We're going to be taking a deep dive into hyperkalemia. So if you want to learn more about that specific electrolyte imbalance, then I will see you back here next week for that. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.
Do you find it hard to sleep at night? Then the Sleep Cove podcast can help you. Hi, I'm Christopher Fitton, the voice and clinical hypnotherapist behind Sleep Cove. Sleep Cove features sleep hypnosis, meditations, and bedtime stories, all designed to help those of you who struggle at night to achieve a restful and peaceful night's sleep. Search for Sleep Cove on Apple Podcasts or Spotify and see why Sleep Cove helps millions of people sleep deeply all night long.